Orchidia Pharmaceutical Industries proudly announces the IuPros can now be stored on the shelf at temperature not exceeding 30 Celsius for the proposed shelf life 2 years. IuPros is now stable with no significant physical or chemical changes at 30 Celsius for the proposed shelf life 2 years. IuPros shows the best tolerability profile across multiple dose prostaglandins analogs. Another product for your glaucoma patients is Travanorm. Travanorm helps more patients achieve desired IOP reductions. Thank you for your time.
We would like to welcome you to the 11th episode of Glaucomatology 2020 by the Egyptian Society for the Glaucomas. This is the 11th episode and the one before the last. And in this episode, we start actually, it has a varied and rich content. Following the two sessions, number 9 and number 10, which involved glaucoma surgery and trabeculectomy techniques, we miss a very important point. I think everybody of us is looking for it, which is tackling the glaucoma bleb, managing the bleb failures and managing the post-operative trabeculectomy blebs. So this talk will be given to us by Professor Dr. Adel Abdelshafik, Professor of Ophthalmology at Ain Shams University. He is one of the best actually covering this topic, and he is always updating his content in this regard. So we are looking forward for this. Following this is a very important, another very important issue, which is how to deal with our glaucoma patients. Dealing with our glaucoma patients does not simply involve, here is your prescription, here is your anti-glaucoma drugs, please use. Here is no, you need a surgery, please come tomorrow to have your surgery. We all know that management of glaucoma is not simply like that. So here comes the talk of Professor Dr. Tarek Elbromboly of Zagazig University about how to deal with the glaucoma patients, how to talk with the glaucoma patient, and how to wisely manage and judge the situation with each patient. And then we have a pause and we look for we cannot leave you just by the current trends of glaucoma management, but we have to look for the future. And we all know about MIGs. It is very well spread in the United States and Canada, and probably just starting to touch other places. And everybody wishes, oh, I'd like to do, or I should do the MIGs techniques. So we have, again, the wise and the knowledgeable talk by Professor Dr. Tarek Ragaiey from Tanta University, who is going to put this into perspective, give us a note. We need to know all about what is going on in this MIGs technique, and then is it applicable in our practices or not? Will it be applied in the future, these same techniques or others? So this is a third rich talk by Professor Dr. Tarek Ragaiey. And again, last but not least, as you probably hear, there are a plethora of new drugs coming into the international market, completely different from the ones we already have in the past few years. So there are some new drugs coming, and already they are in use in Japan, maybe for already 6 or 7 years now, and in the United States they were approved 3 years ago. So Professor Nader Bayoumi of Alexandria University and the coordinator of this glaucomatology webinars will be talking in brief about these new drugs and the medical part for the management of glaucoma in the future. So we start our 11th session and welcome you all again. Dr. Adel Bey for tackling the glaucoma bleb. We are really all ears.
Thank you, Dr. Ahmad. I guess by now you should see my screen.
Yes, it is there, Dr. Adel.
Thanks. Okay, I might talk about the management of the glaucoma bleb. Actually, when we do a subscleral trabeculectomy, we need aqueous to come to balloon the bleb and to compress blood vessels in the wall of the bleb. Blood vessels is the main source of fibrosis. So if we decrease the amount of congestion around, we are in a better situation. To achieve a good aggressive aqueous, this is during the surgery. After I close my scleral flap, I go through the paracentesis, inject aqueous in the anterior chamber, and see the amount of aggressive fluid coming from the scleral flap. If it's okay, that's fine. If not, then I'll make some management to make the egress more. If it's too much, I can take more stitches to lower it. This is one of the things I can do. Just make pressure on the stitch a little bit. This will loosen the stitch and get aqueous more. Again, by the end of the surgery, after closing the conjunctiva, I recheck. I go to the anterior chamber and check the ballooning that will occur at my bleb and make sure that the scleral flap is filtering the way I want. And at the same time, I check that the conjunctiva is not leaky. Not only having aqueous, but we need this aqueous to be healthy, free of inflammatory cells. So in situations like these, we need to use mitomycin during the surgery, like prolonged use of topical medication, like previous or concomitant surgery for my glaucoma surgery, like cases of uveitic glaucoma or uveitic glaucoma. In such cases, we know that the risk of fibrosis is high because the aqueous is not healthy. Then we apply mitomycin during the surgery. My main talk about the first 6 weeks following the surgery. This is the most important area to cover and to deal with. If you manage this part of time in a good way, then most probably you can get away with your surgery with a successful surgery. When I look at a bleb, I check these 4 points. The first is the height and the extent of the bleb. The height of the bleb can be compared by the corneal thickness. It can be one thickness of the cornea, can be 2 times, can be 3 times thicker than the cornea. And I can record this from visit to visit to be sure that it's going on fine or it is getting less and less. The extent, you can measure it either in millimeters or you can take it in hours. Here, this is around 4 hours extent of the bleb. Again, the severity of congestion. Here, this is the average congestion compared to the surrounding conjunctiva. Up here, this is avascular bleb. And here we have 2 grades of increased congestion. When you see blood vessels, it's not only the congestion, but you need to check if there is corkscrew vessel appearance. This means that there is some fibrosis is going on and the blood vessel, instead of going straight, start to be in a corkscrew. And then you need to check, is it located in one area of the bleb or is extensive, covering so many areas of the bleb? Again, the microcystic changes. If you can see the microcystic changes, then this is a good healthy sign that the bleb is functioning. In the literature, it's written that it appears after a couple of weeks or months or something like that. Actually, you can see it very, very early in a day or so. This is the way to see it. This is a slit lamp on the bleb. This is the section. You look just to next to the section. You see it at the light coming back from the sclera. These tiny bubble areas, the more you see them, the more the microcystic changes are there, then you are happy that the bleb is going on and it is functioning. This is simply histologically clear areas in the connective tissue under the epithelium. Again, the extent of the microcystic the microcyst, is it located in one area or is it all over the bleb? Lastly, you need to check the transparency of the wall. In this photo, you can see through and you can see the scleral flap. This is a thin wall, you can see through. This is a very nice situation. But when it turns opaque like this, this indicates that you may pass into problem and you have to do something. Fibrosis will turn the wall opaque. We have two types of fibrous tissue. The first is contractile fibrous tissue. The second is non-contractile fibrous tissue. The contractile fibrous tissue will induce corkscrew vessels, and by time it will bring the wall of the bleb down. So we have an episcleral fibrosis, or the fibrosis can be between the two layers of the scleral flap. This is an intrascleral fibrosis. On the opposite side, the non-contractile fibrous tissue, as aqueous is coming beneath, it will push the fibrous tissue and the conjunctiva ahead. And we are going to end with encapsulated cyst or tenon cyst. This is the green conjunctiva and this blue is the fibrous tissue. And gradually you have a localized swelling like that, and gradually it's not functioning. So in this photo, bleb is getting flatter and flatter with congestion. And on the other side here, the encapsulated cyst, you have a localized elevated bleb, and gradually it will lose its function. You can use UBM to differentiate. This is the shape of the tenon cyst, conjunctiva fibrous tissue, and you can see the bleb is going on here. Episcleral here, fibrosis on the surface. Intrascleral, you don't see between the two layers. Here you can see between the two layers of the scleral flap you already done. Encapsulation, if it's there, just check is it localized or covering the whole area of the bleb. So these are the points every time you look at the bleb, evaluating it: the height, the extent, the vascularity, the microcystic changes, and the transparency of the wall. For example, this bleb, it's elevated, double the thickness of the cornea. It extends 4 hours. Congestion is slightly, wall is transparent. Here, the extent 4 hours, it's not congested, wall is slightly opaque. Again here, you can see the extent, and you can see through, congestion is moderate, and so on. This is the way every time you check a bleb, you cover all these points. Now let's have some of the bleb problems. This patient, I did him subscleral with mitomycin, IOP postoperative 6, and on examining the bleb, it is severely congested and it's not elevated. So I did a CDL test and I found conjunctival leak. I put him a therapeutic contact lens. It's a large diameter 18mm lens. I applied. After 2 days, patient is back. I check, leak was still there. So I keep the contact lens again for another 2 days. And this is after 4 days. As you can see now, the congestion is much less and we have an elevated bleb. This is the first situation, and this is after application of a contact lens for 4 days. So simply, if you miss this, you're going to lose such a surgery. Sometimes contact lenses is not enough, then you have to get the patient to the theater and manage the leaking area with stitches of the conjunctiva. Again, you may have problem of aqueous not reaching to the bleb, like you get obstruction of the internal ostium. This can be seen with a gonioscope. This is the patent ostium. This is occluded by the iris. If you have such a situation, you have to deal with. You can try to shrink the iris to pull the iris away from the opening. In such a situation, we use large spot size, not much energy. Then the iris will shrink. This may be successful. If not, then you have to go surgically and do it. This patient was a case of non-penetrating glaucoma surgery, and I did laser to the dismus membrane. I did a huge opening, and then I get the iris coming, including the ostium. So I get the chance when I was doing phaco to get the iris away, and this is the post-operative appearance. Again, you may have flattening of the bleb because there is some fibrous reaction. In such a case, you can check it by massage. If I ask the patient to look down and I use my thumb pulling the upper lid up, and at the same time I'm pressing on the globe and I'm noticing the pressure, how much aqueous is coming and how much elevation will be there. So it depends. By experience, you start to notice if you need to press long time or short time, and accordingly, if this is successful, this is before massage, this is after massage, then you start to train the patient to do it himself. The pressure maximum should be 30 seconds at a time. And according to my response, one patient, I will ask him to make a pressure for, say, 10 seconds. Another patient can be for 30 seconds and have a rest for half a minute, then another 30 minutes, 30 seconds, and so on. And then this is not universal for all patients. This is depending on the response. And again, it is not the same all over the time. Sometimes you need to change it after 2-3 days to make more pressure or to minimize the pressure. For the patient, he should do the pressure from the lower lid away from the bleb. So you ask the patient to look up and do the pressure through the lower lid, and he should do it in front of you and then see the response. Then don't leave it like that. Ask the patient to come the second day and see what the situation. This patient, when I see him the second day, I found folds here and the dismus membrane was localized edema in the cornea. I asked him about the massage. It was done 2 hours earlier. IOP was 2. So this patient, he's doing much pressure. I asked him, don't do any pressure, and the second day, pressure went up to 8, and the edema would almost disappear. So in this patient, I told him, do less aggressive massage. So every time you have to check the amount of pressure and the effect that the patient is doing. If you have a tight suture, then you have to deal with it like by suture lysis with the laser. Let me give you this example. This is a diabetic patient with neovascular glaucoma. The retina colleague gave him a Vaseline injection 1 week before. There was corneal edema, and he couldn't do pan-retinal photocoagulation, so he was referred to me. I did him subscleral trabeculectomy, mitomycin. The first post-operative day, there was no bleb. I tried massage, bleb was not formed. I usually close my sclera flap by 2 stitches, so I use the laser. I make suture lysis of the first stitch and wait it for 1 hour, try to make some pressure, nothing. Then I put the patient back to the laser machine and remove the second. So totally there is no stitches in the sclera flap. waited for some time and make pressure massage again, no elevation. So I went to the operating room. This is the situation. I usually close my conjunctiva like this. It's an L shape. So with the insulin needle, I bend it. I go in between the stitches under the conjunctiva to the scleral flap. I'm trying to be very careful not to injure anything, just aiming to the site of the scleral flap to release the fibrous tissue already there after 1 day of the surgery. I'm coming from the opposite side. I'm waiting for aqueous to come out. Before that, I'm not having any success. So up till now, cutting tissues, fibrous tissue, but nothing, no ballooning of the conjunctiva. Try to avoid puncture the conjunctiva. Maybe it may puncture once or so, but don't make much damage to the overlying conjunctiva. Now I'll go a little bit in the direction of the anterior chamber. Still no conjunctiva elevated. Now there is this ballooning. Now I know I get my aqueous. What are the failure signs if the bleb is getting, the height is less, the extent is less? It's if the vascularity is more, especially when you get corkscrew vessels, if the microcystic changes that was present in the early start to disappear, or if the wall turned opaque. In such a situation, we have several things you may try. Massage is one of them. Again, we can try to give subconjunctival injection of fluorouracil, or if it's not available, as we don't have it in the last 2-3 years, we can use subconjunctival injection of mitomycin. Can do it in the clinic, local anesthesia, microsponge soaked with the anesthesia drop, touch the area where the injection will be. You can use a speculum. I usually in the clinic just use my fingers to open the 2 lids. Then I inject 5 millimeter of 5-fluorouracil. This is 0.1 milli volume. And after the injection, keep the lids open, because if you allow the patient to close immediately, he will press on the bleb area and fluid that will come out, may injure the cornea. The site of injection is away from the bleb, maybe 90 degrees or even closer here, but avoid the amount of injection to get into the bleb. You can repeat this twice per week, maximum 12 injections, total dose of 60 milligrams. In this example, it was a 32 years patient. He got congenital glaucoma. He did multiple surgeries before, twice glaucoma surgery and once cataract surgery. So my options were either to go for subscleral with mitomycin or valve or diode cycloablation. So we started and agreed to start with the subscleral. This is the appearance 2 weeks after the subscleral with the mitomycin. I didn't like the congestion. This is 2 weeks following in a young patient, and this is not happy for me. So I started the injection. This is the appearance after 5-fluorouracil given twice per week for 3 weeks. And the patient went fine, but later, after 3 months, again, the pressure went high and we had to go for Ahmad. Again, needling is another option. You have to do needling. It's better to be in the operating room. You have to sterilize the area, applying speculum, local anesthesia on the area where you're going to do the surgery and where you are going to fix the globe. So we have local anesthesia by the sponge here and there. The insulin needle bended under the conjunctiva. Then I'm aiming to reach the scleral flap. So I go making multiple punctures on this side, and gradually I pass under the scleral flap to come out from the opposite side. This is much easier if this is your patient and you can see the scleral flap. But if the conjunctiva is not transparent and you don't know the previous surgeon, what have you done, you cannot be safely do something like that unless you can see the edges of the scleral flap. So on coming out from the opposite side, we are careful. And as you notice here, there is some fluid coming on each side of the scleral flap. I'm not injecting anything. I'm depending of aqueous to appear. So this is another case, encapsulated bleb. So it's just we go and make punctures in this bleb. Again, we avoiding coming out and making multiple injuries to the conjunctiva on the opposite side. In this example, I tried to go under the sclera. I'm coming from opposite side several times, no aqueous skin. So I decided this is a case of intrascleral fibrosis. The whole scleral flap is adherent to one another, the superficial to the deep scleral flap. So in this case, I changed the direction of my needle and I went into the anterior chamber. On doing that, you will notice that aqueous will come out and ballooning of the conjunctiva will start to appear. This manipulation of needling can be done several times. It can be done in a long interval. These days we don't have 5-fluorouracil, so we can inject mitomycin under the conjunctiva. The dose is 10 micrograms. We just prepare this concentration, 0.2 milligram per milliliter. We take 0.1 of them, 0.1 milli, and add 0.1 milli of lidocaine. So the final concentration will be 10 micrograms. We inject 0.1 milli under the conjunctiva of this mixture. Just check this. This is one of the papers that were done. They were making needling and they used mitomycin, and this is the range of the surgery. After this is the range of the time of the needling. It was, for this paper, it was between 6 months up to 30 years. And they get a good, around 3/4 of the cases were successful. So you can do it anytime. You will not lose much, but you can get success in so many cases. Lastly, if all this is not effective, then you can go for external revision. You make exposure for your site of surgery, inject saline to separate the conjunctiva, open the conjunctiva, then dissect to take the fibrous tissue away, apply mitomycin, then close the conjunctiva. Just for the sake of time, this is my last case. A child, 9 years old, I did him subscleral trabeculectomy with mitomycin. This is the first day post-operative. Pressure was 4, and this is the conjunctiva open. 4 days after the surgery, pressure went up to 14, and I don't see the wall is opaque. I don't see my scleral flap. Again, notice here the congestion. This is the first day, and this is the same vessel after 4 days. As you notice, it's turned to be more congested. Again, the wall is not transparent. And I try to make massage, and I noticed there is elevation here. Here the bleb before the massage, and this is after massage. And again, we have fluid here. So I know that the bleb is still, the scleral flap is still going on. But this situation, I will be in a failure very soon. So I went him back after 1 day, 1 week of the surgery, and I opened the conjunctiva, and this is the tenon, so much thickened, fibrotic, and if I leave it like that, 100% I should have been into a failure. So I dissect this thick tenon and remove it away. I don't have a video of the original surgery. If I had it, then I should check, was it that thick during the surgery? Most probably it was not, because if it was like that, I should have removed it in the first place. Usually people do not remove the tenon unless it is so thick and opaque. So this is the first day post-operative, 4 days. This is the time of the surgery. This is the second day. This is after 3 days. Then after 10 days, you notice the situation is quite different. And this is after another week. This is now around 2 years post-operative, and all over the chart was going fine. I use here mitomycin 3 times during the surgery, when I dissect after 1 week, and when I remove the stitches, I also applied, I injected mitomycin subconjunctival. So I tell you that the first 6 weeks are the most important weeks to check the patient, to check the bleb, to notice if the situation is going fine, or you need to interfere and correct what is ever necessary. Okay, so this is the end of my talk, and thank you for your attention.
Professor Adel Abdelshafik, thank you very, very much, sir, for this excellent, as usual, presentation. Ever since I was a resident, actually, I was really fascinated by your mentorship very much. Now, if you would allow me, please, just one very short, simple question, sir. You were asking, sir, that you were mentioning, sir, that you check the transparency of the bleb. Now, looking for the transparency of the bleb, do you, while doing the trabeculectomy, do you excise Tenon's capsule? That's the question. And how do you differentiate transparency of the bleb from a bleb that has become thin and cystic pathologically, the one that we are always afraid of for infection and late infection, the problems of mitomycin C? These are 2 really key issues for me, sir, please. The tenon excision and the differentiation of the transparency, the one that is healthy from the one that has become cystic, and the one that would make us fear of infection. Please, sir.
Regarding removal of the tenon, there is controversy. Some of the people will say, yes, we should remove it. This is the source of the fibrosis. And others will say the reverse. If you remove it, you are inducing some injury, and this will induce fibrosis. So sure, actually, I don't remove it unless it's going to interfere with my visualization later. I usually don't rely on a releasable suture. I usually have my stitches, and if I need to take them away, I put the patient on a laser machine and make a cut. So it should be transparent to see the wall, but this is my main point, to remove it or not. The second is, if you are dealing with a very thin cystic bleb, actually the conjunctiva will not be of a normal vascularity. It will be avascular. So this is the sign. The normal conjunctiva, you have a tissue with blood vessels in. But if gradually the vessels disappear, and the conjunctiva is getting thin and thin, so actually you can see through, you can see maybe some tissues beneath, not the scleral flap already done. This situation usually has to appear, it takes a couple of months or a couple of years to appear. So it's not mixing. The healthy conjunctiva, this is something we see every day in the normal patients, but with the Then avascular, this is something situation you cannot mix them together.
Okay. So vascularity here is a key. Disappearance of blood vessels that were normally present before that is a key issue for differentiating both.
Yes.
Sure. Okay. Thank you very much, sir. If we had the liberty of time, I would not leave this topic for hours and hours, but for the sake of time, we would have to move forward. And Professor Tarek Elbromboly, please take the lead, sir.
My short screen open.
Yes, evident, sir. Thank you. Please, sir. How to handle our glaucoma patient and to survive with glaucoma. A really, really big issue, as Professor Khalil presented.
It is an honor to me to join this glaucomatology, the session before last one. Alhamdulillah. And we will speak about advices to glaucoma patient, how the glaucoma patient can live with his disease, with this chronic disease. What is the wrong to do or what is right to do? There is always no advice because the patient does not ask or we have no time to answer. And the patient does the opposite of what the doctor said. And if he look in internet, there is no enough support in Arabic. Our aim is to remember together the advices that we should give to our patient with glaucoma. Pick up more about how to maintain a healthy lifestyle, healthy vision while living with glaucoma. Working with doctor. Ensure that your eye condition is identified early and managed. Know your eye pressure and monitor any change. Your doctor your concern and any questions. He is willing to explain your case and treatment option and is available for call and checkup. You always have the right to seek a second opinion if you don't feel confident and comfortable with your doctor. This is a right of the patient. What about living with medication? Once you started therapy, generally continue for the rest of your life. Take your medication and follow your doctor instruction. Please put the drug or make the drug a part of your daily routine. For example, putting the drops in the morning before getting out of the bed or during the breakfast, as you like, but make your medication a part of your daily routine. Keep your medication in a visible place. ما تحطوش في الدرج. Not in the box. حطها دايما على الشفونير عشان تبقى شايفه. At home and take them with you if you travel. Don't stop the drug or use it sporadic because this increases the risk of blindness and the worsening of glaucoma. Report any change to your doctor, especially if there is eye irritation, discharge, or whatever. If you forget to take your prescribed medication, take your medication when you remember, and then go back to your regular schedule. Get an extra supply of medication in case of you misplace a bottle of eye drop or pills. دايما يبقى في عندنا ازازه زياده علشان لما القطره تخلص في اي وقت او تضيع منه يستخدمها. After putting the drops into the eye, gently press the corner of the eye for 1 or 2 minutes to decrease the systemic side effect of local drops. When using more than 1 drop, please wait for 5 minutes or at least 1 minute before using the second drop for fear of washing up effect. It is important to have your eyes examined on a regular basis to check for glaucoma and to follow it. Being well with no visual symptom does not mean that you are all right, as the vision loss caused by glaucoma comes on so gradually, so we call the glaucoma the silent thief of sight. Schedule your next checkup before you leave the doctor's office and put the appointment on your calendar. Go for checkup before you go on a long trip or start a long-term demanding project. Write down any question you have before you see your doctor, and during your checkup, bring this list of questions and write down your doctor's answer. If you use contact lens, continue contact lens even if you use eye drops. Take the eye drops when the lenses are not in your eyes. Your ability to wear contact lens may be affected after surgery due to the presence of the bleb. What about eye wrapping? Please don't wrap your eyes. Such maneuver raises eye pressure and may contribute to further optic nerve damage. Systemic disease, you must control diabetes, obesity, and high blood pressure that is linked to elevated eye pressure. Being overweight is associated with high intraocular pressure, but there is no conflicting evidence about the association with glaucoma. And overweight is associated with sleep apnea, which is another risk factor in glaucoma. Control of the blood pressure and avoid hypotension, as untreated systemic hypertension is associated with glaucoma. On the other hand, excessive lowering of the blood pressure may be the cause of progressive visual field loss despite of proper control of intraocular pressure. What type of work can I do as a glaucoma patient? No specific work is particularly good for or bad for glaucoma. You can use your eye. Using your eye is not harmful. They do not need to be rested. Near work, encourage your eye to focus up close and increase aqueous drainage. And similarly, longer distance viewing does not harm your eyes, like watching TV or driving or going to a movie. Intraocular pressure can double within 20 seconds when playing a wind instrument, but return to baseline almost immediately. Driving. Can I drive, doctor? Yes, you can drive if your visual acuity with both eyes open with or without glasses is a 6/12 or better. With a binocular horizontal visual field of 120-degree minimal, with not less than 50 degrees on each side of the central, and no significant field defect either within or encroaching onto the central 20 degrees. What about clothes? Don't use tight necktie, because tight necktie increase intraocular pressure in post-normal subject in glaucoma patient. Exercises. Can I do exercise? Yes, it is very helpful to you. A regular effective exercise program can go to a long way toward reducing your insulin level and protecting your vision. 3 months of regular exercise reduces the intraocular pressure by average of 4.6 millimeter mercury. With cessation of this exercise, the intraocular pressure return to be elevated. Power walking is very good. And the glaucoma patient who walks 4 times per week for 40 minutes were able to lower their intraocular pressure. What about swimming? Swimming is a sustained cardiovascular exercise that improves the condition of the vascularity of the retina. There is no additional risk in diving for glaucoma patients. يعني يقدر يعوم ويقدر يغوص كمان. What about heavy weightlifting? You can continue lift weights, but to avoid a Valsalva maneuver. This maneuver will increase the intraocular pressure, which can be harmful to the patient with moderate to severe glaucoma. The only exercise to be avoided are those in which your head is held below your waist. Keeping the head below the heart for extended time could increase the intraocular pressure. Any exercise that gets the heart pumping is good. Advise 20 minutes of cardiovascular exercise 3 or 4 days a week. Exercise may also improve blood flow to the retina and to the optic nerve as well. While exercise is beneficial in most cases, but it cannot replace glaucoma medication. ما حدش يقول انا بعمل رياضه عشان كده هبطل، والرياضه بتنزل الانترا اوكلر بريشر هبطل القطره بتاعتي، ما ينفعش. What about eating? No specific food are particularly good or bad for glaucoma treatment. Eating more antioxidant-rich food, showing that higher intake, some studies showing that higher intakes of fruits and vegetables is associated with a lower risk of glaucoma. Lower your insulin level by avoiding sugar and flour. Drinking. Drink 6 to 8 glasses of filtered water daily at least, but avoid ingestion of a large volume of fluid rapidly. A significant rise in intraocular pressure may occur after drinking a high volume, about half or 1 liter, over a short period of time, 15 minutes. ودي بتحصل دايما في الصيام، ان العيان اللي عنده جلوكوما يبقى صايم، يبقى عطشان، يشرب كميه ميه كتيره جدا وهو عشان ساعه الفطار يشربها، ولكن in distributed time، ما يقدر ما يشربهاش in a short time. Avoid coffee and other stimulant. Use caffeine-free product. Coffee elevate intraocular pressure, but it seems safer to ingest not more than 2 cups of coffee a day. You may use herbal, as we know green tea, improve or protect the condition of the retina in laboratory rats. Avoid alcohol. Alcohol may lower the intraocular pressure initially, but daily alcohol causes a slight elevation of intraocular pressure. Can I smoke? Avoid, please, smoking. The current smoking is possibly related to glaucoma risk, but there is no study has found an association between glaucoma and past history of smoking. Smoking marijuana could lower the eye pressure, but there is no scientific evidence that marijuana is more effective than drug currently available. يعني ما حدش يقول انا هاخد اشرب marijuana وهبطل الايه الدراجز. الدراجز is more effective. What about sex? Sex can be a part of healthy physical and mental lifestyle, and it is okay for glaucoma patients. And there is no study show that sustained sex affect eye pressure or be harmful to the eye health. يعني برضه ما حدش يضحك على عيان جلوكوما بيشن ويقول له السكس ايه مضر ليك. There is no harm to maintain your normal relation. The patient usually asks about Viagra. What about Viagra? Viagra did not produce any significant change in the intraocular pressure in men with chronic open-angle glaucoma. Sleeping. Avoid sleeping with face below the level of heart. Try to avoid sleeping face down and to avoid any pressure on one or both eye from pillows or bedding. Sleeping with physical pressure on an eye can accelerate glaucomatous damage. And there is a study correlating the sleep position as a factor in asymmetrical visual field loss. We can find asymmetrical visual field loss due to pressure on one eye during the sleep position. Sleep apnea syndrome is associated with glaucoma, and people are more at risk for sleep apnea syndrome if they are male, obese, snore, drink excessive alcohol, and smoke. Anesthesia. It is better to use peripulbar anesthesia than retropulbar anesthesia if you can, or if you need a surgery in the eye. General anesthesia, avoid general hypotensive anesthesia for a long time. This is damage to the optic nerve. And avoid lowering the head below the heart or pressure on the eye for a long time during anesthesia. Psychological health. Don't worry. Worry, fear at the time of diagnosis will take time to disappear. And if you learn about the disease, you will find that there is many steps you can take to help your management of glaucoma. Even if you lose some of your vision, you can do rehabilitation to continue leading an active life. Reduce the day-to-day stress in your life. Be sure to take a time to make a time or to take a time for fun and relaxation. Teach your friend and relative about glaucoma, importance of eye check-up, even with no symptoms. In conclusion, your advice to your patient is to take care of your eyes and follow your doctor's instruction, eating healthy food, getting enough exercise, not smoking, not ingestion too much caffeine, and staying at a healthy weight are important. Space out your fluid intake and lower your salt intake. Stop alcohol. Maintain a healthy blood pressure. If you snore, exclude sleeping apnea. Avoid lifting heavy weights. Avoid playing wind instrument. Avoid head down position. Be happy with Viagra or without if you can. Take good care of yourself and your eyes and get on with enjoying your life. Thank you very much.
Thank you very much, Dr. Tarek, for this excellent presentation, as usual, and very interesting. I actually myself feel a great relief on hearing these instructions, sir. Not speaking of the patient, thank you very, very much. I would like to highlight just two issues. First issue, do you have any recommendations, sir, for a reminder for the patient whether they've taken or not taken the medications? And you've mentioned, sir, in the first slide, make your medications a part of your routine day.
Yes.
Okay, we have the problem, even I myself in the meds I'm taking, is that when I do my routine, I just forget, did I actually take that medicine or not? So is there any, again, tip or recommendation for you to tell the patient as a reminder for them, they've put their eye drops or not?
The first simple task that he will do, it changes the position of the bottle. If he put the bottle in the right side of the desk, after putting it, he must put it in the another side. This is will help him to remember if it is put it or not.
Thank you very much. This is a really, really great tip. Thank you very much. Now, the second intriguing question, sir, which we always face actually, is about pregnancy and mode of delivery. Is CS, cesarean section, versus normal vaginal delivery with all its bearing down and severe Valsalva maneuver for a long time? Let's speak especially of a primi gravida, which is going to stay in the second stage for a long time. Any recommendations, sir, about CS versus normal vaginal delivery in a pregnant glaucomatous female?
Delivery had a risk of peering or Valsalva, but Valsalva for a short time is not affecting the glaucomatous damage. But we cannot leave the patient doing Valsalva for 1 hour. For example, you must stop the normal delivery and shift to cesarean. But in the cesarean, we must control in blood pressure, because I show many patients with glaucoma that showing marked deterioration in visual field after delivery because of the hypotension that accompanied with the delivery. This we can ask the patient to deliver normally without harm, but not for a long time. If it's obstructed, the doctor will try again and again. It is very harmful to our glaucoma patient.
Okay, so timely, well-managed, normal vaginal delivery would be okay for a pregnant glaucomatous female. Now,
yes.
Okay, now let's go for cell phones. But since we're speaking of the routine use of instruments that our patients can use, what about the use of cell phones, especially that now social media, of course, that people use it for long time, staring at them? Is there any data related to that?
I didn't hear. Please. What about?
The use of cell phones, sir. By the way, it's another question actually for myself, because I face this with my glaucoma patients. They ask me, is the use of cell phones for a long time, for long hours, staring in the cell phone for long hours, does it affect the IOP control? Does it raise the IOP or not? Because I've been asked that question for a long time, from several patients.
I haven't a definite answer for this question.
Sure. Okay. Thank you very much, sir. Now, for the sake of time, Orchidia has a promo or a short message to deliver to us. So let's be with our sponsor for a minute.
Hello, doctor. Greetings from Orchidia Pharmaceutical Company. I hope you, your family, and all your beloved ones are safe and in good health. Today, I'm going to talk about our latest introductions for your glaucoma patients. Taflopro single-dose unit offers better IOP control to reach a target IOP. Taflopro single-dose unit reduces IOP significantly in patients with prior prostaglandin monotherapy. Taflopro single-dose unit ensures no severe hyperemia experience with other prostaglandins. Another product for your glaucoma patients is Taflopro plus single-dose unit. Taflopro plus single-dose unit provides numerous benefits when compared to non-fixed combinations. Taflopro plus single-dose unit offers extra IOP control up to 22.3% when switching from prostaglandins analogs. Taflopro plus single-dose units offer a better local comfort. Thank you for your time.
Thank you very much, Wakilia. And
may I interfere? One thing.
Please do, sir. Please do.
There's application on the mobile phone. It's called MediSafe. You can program it for anything you are taking as a medication. It will give you a reminder, and it still will give you a message every, say, 30 minutes or 20 minutes that you have missed your drops. And you can attach this, you can print out of an Excel giving you what was going on in the previous period, how much drugs you've missed. So it can be there on the Android or the, on the other, I don't remember the other company. Okay,
yes,
thanks.
Thank you. Thank you very much, sir. Yes, that's a very useful application, really. Okay. Now, so let's move on to our next speaker, Professor Tarek Ragaiey, that is going to give us a glimpse at the future, at the present future, actually, that we are willing very much to explore the issue of MIGs. Professor Ragaiey, please take the lead.
Thank you, Professor Dr. Nader. It is of my great honor to be in this distinguished meeting, and I'd like to thank Professor Dr. Ahmad Khalil, Professor Dr. Nader Bayoumi for my invitation, and also I'd like to thank Professor Dr. Adel Abdelshafik and Professor Dr. Tarek Elbromboly for their great presentation. And today I'm going to talk about MIGs as expanding options for glaucoma treatment. MIGs procedures are designed to lower intraocular pressure by improving aqueous humor outflow with minimal disruption to the sclera or conjunctiva with or without an implanted device, or by reducing aqueous production selectively. Outflow enhancement can be accomplished by facilitating access of aqueous humor to the Schlemm's canal. This is the canal-based MIGs, the suprachoroidal space, or the subconjunctival space. Reducing aqueous production can be accomplished through selective direct laser ablation of the ciliary processes, the structures that produce the aqueous humor. What is the definition of MIGs? According to Ahmad, which has started this nomenclature for these devices, it is ab-interno approach, minimally traumatic, at least modest efficacy, extremely high safety profile, and rapid recovery. In this flow chart, we can show different types of MIGs and traditional glaucoma surgery. Here, the microinvasive, here the traditional. You can see some overlap here. Some implants are considered traditional because they are subconjunctival and can be considered also in MIGs if they are ab-interno, can be considered traditional if they are ab-externo. But as we go from left to right, there is increasing amount of dissection work for glaucoma surgery. MIGs are not designed to replace trabeculectomy in advanced glaucoma. Rather, surgeons are using MIGs procedures in their mild to moderate patients who need lower intraocular pressure, but in whom they are reluctant to operate because of the side effects associated with trabeculectomy. This is according to Ahmad in his editorial in Ophthalmology 2015. He also said that MIGs devices are designed to address the treatment gap that exists between medical and the laser therapy and the more aggressive traditional surgical option. This is the gap. They are trying to fill with MIGs for mild to moderate glaucoma patients. This is a conventional glaucoma treatment algorithm. We are always practicing one medication, multiple, selective laser trabeculoplasty, again, multiple medications, the trab, second trab, or tube. This is the gap MIGs trying to fill. In mild cases, mild to moderate, here is the gap between drugs and phaco MIGs, and if the case is severe, sure the trab and the tube will work. What are the indications of MIGs according to the American Academy of Ophthalmology in June 2020? Patients generally are good candidates for MIGs if they have mild to moderate glaucoma and are intolerant or non-compliant with drops, or if their IOP is not controlled with topical eye drops or laser trabeculoplasty. MIGs procedures can also be used to reduce drop dependence at the time of traditional phacoemulsification surgery in patients whose disease may even be controlled with medications. MIGs are often not sufficient treatment for patients with more advanced glaucoma who require a low IOP goal. For these patients, traditional incisional surgery and glaucoma drainage implants are still indicated. What are the types of MIGs? There are 5 types of MIGs according to the American Academy and in the literature. Trabecular meshwork bypass by stent placement. This is a physiological pathway. We are trying to bypass it, as we know, as we all know that the juxtatrabecular meshwork is the area of most resistance. Either by stent placement, there is eye stent inject, and the hydrous microstent, and all of these are devices. The second type of MIGs is the trabecular meshwork bypass by excision of the trabecular meshwork tissue. And I think this type of MIGs is very suitable for our community because it is cost effective, much less cost effective than the devices. But the general advantage of these MIGs procedures are the ability to bypass the trabecular meshwork and form a direct pathway to the Schlems canal for 3, 4, or more clock hours, sometimes even engage for 360 degrees. Importantly, also no implant is required, and these goniotomy trabeculotomy procedures, they are ab interno goniotomy trabeculotomy procedures, can be performed as a standalone procedure or combined with simultaneous cataract surgery. Also, the third and the big advantage of this group of MIGs is they are cost effective. General disadvantage are the risk of cleft closure from residual trabecular meshwork leaflets, and the IOP reduction is limited by episcleral venous pressure and Schlems canal resistance. And this is especially in incisional and not excisional type of these MIGs. Examples of incisional, excisional of the trabecular meshwork MIGs procedures: the trabectome, a machine like the phaco with disposable hand piece, expensive. Cahook dual blade is less expensive, but it is single use. Tanito micro hook, the same idea of the Cahook, but it is reusable. Sharp, it is like Sensi hook with sharp point and can penetrate the trabecular meshwork and excise it. In some videos on the YouTube for MIGs surgery, some surgeons have used insulin, 25 gauge insulin syringe, and they get it 90 degrees like this, and it has done the same work. And in the GAT procedure, you can do 360 ab interno trabeculotomy with 5O Brolin suture. And that's why this group is very cost effective, and they are also effective and comparable in efficacy to the devices. The Trab 360, this is a device, and in some types it adds also visco to dilate the trabecular meshwork before incising it. The third type of MIGs is enhancing aqueous outflow through the suprachoroidal space. This is the CyPass microstent FDA approved in July 2016, but the device was withdrawn from the market in August 2018 based on the result of the 5-year trial, which demonstrated a significant decrease in the corneal endothelium cell counts in patients undergoing CyPass with phaco compared to patients undergoing phaco alone. Number 4, the shunting aqueous outflow into the subconjunctival space, similar to traditional filtering surgery, decreases IOP by shunting the aqueous from the anterior chamber to the subconjunctival space, and the Zen gel stent implant is the currently only FDA-approved device which utilizes this approach. And because this approach results in the formation of a filtering bleb and needs use of mitomycin and the same work on the filtering bleb, there is a debate to whether this approach can truly be classified in the MIGs surgery or not. Number 5, reduce the aqueous production by the endocyclophotocoagulation. The next point in my presentation, I'm going to show some of the tips for angle surgery if we are going to go for angle surgery, which is trabecular bypass incisional excisional surgery. The first tip is gonioscopy. Gonioscopy, as we all know, is used to classify and diagnose glaucoma at the slit lamp in all patients with glaucoma. MIGs requires a higher skill level because it requires the use of a gonioprism mirror under an operating microscope to visualize the ocular structures that require treatment. That's why you need to examine every patient on the slit lamp. You need to see the angle and train very well, but still the surgical gonio surgery needs more skills. Why? Because this particular skill requires more manual dexterity because of the surgeon must use one hand to balance the gonioprism on the cornea to permit visualization of the structures requiring treatment, and simultaneously the second hand to carry out the procedure. And remember that angle surgery is working in even smaller, more sensitive space within the eye. That is the trabecular meshwork, approximately from 0.5 to 0.7 millimeter width. Several surgical gonio lenses need head rotation of the patient away from the surgeon and the surgical microscope towards the surgeon, as we see here, 30 to 35 degrees. On the other hand, some surgical gonio lenses eliminate the need for any head or microscope tilt. And so you should know which type of surgical gonio lens you need to use. So based on this, whether to tilt or not to tilt the microscope or the head of the patient. Also remember that too much pressure on the gonioprism will get the corneal striae, which will block your view, and too little pressure, you will get air bubbles in the cornea gonioprism interface and have no view. Also, in the tips of angle surgery, how to identify the trabecular meshwork, you have 3 methods. Either by the pigment, and you are familiar, by the trabecular meshwork from your routine gonioscopy and on the surgical microscope. This is the scleral, this is the ciliary body band, scleral sphere, and the trabecular meshwork, or blood. How to provocate surgical gonioscopy. Forced reflux of blood into the Schlemm's canal, relative hypotony, blood reflux into the Schlemm's canal with IOP drop. If you are starting by paracentesis, getting the intraocular pressure lower, you will find the blood will fill the canal, and this actually occurs in almost of the cases during MIGs. Staining trypan blue, also you can stain the trabecular meshwork with trypan blue if it is fairly unpigmented and the blood is not clear, and sure, this is much safer if the case is combined with phaco. Also, in the from the tips for angle surgery, in your learning curve, blunt instrument like iris spatula or blunt cannula can be used to touch the trabecular meshwork, to be familiar with the position and handling of the trabecular meshwork in different techniques. And here in this case, this was in July 2020. I was always using iris reposter and put the gonio lens, and all what I was doing just to touch the trabecular meshwork and get out of the eye. They were traditional phaco cases with no glaucoma surgery, but at the end of the surgery, I was putting the blunt cannula or iris reposter just to be familiar how to find the trabecular meshwork and just touch it and getting back out of the eye. Also from the tips for angle surgery, white appearing of the cleft noted after trabecular meshwork excision is a good sign for ab internal successful trabeculotomy. If you are starting the operation of the trabecular meshwork like that, and you have incised or excised the trabecular meshwork, and you have found this cleft, and even if it is not clear due to the blood, which usually occurs after excision, if you will find it on routine gonioscopy and follow-up of the patient after surgery, this is a good sign. Now I'm going to present two cases. I have done MIGs for them and to see how the MIGs have changed my mind a little bit in selected cases. This is a case of phaco stanito microhook for mild primary open angle glaucoma controlled with 2 medications. And for this patient, the preoperative IOP was 12 millimeter mercury with 2 glaucoma medications. It was already controlled with 2 glaucoma medications and have mild field defect. And when she had dense cataract, I have decided to do ab internal trabeculotomy and I have done this case since only 3 weeks because I have short learning curve for MIGs, but I get some result of 10 millimeter mercury with 1 glaucoma treatment. And here, this is a Tanito microhoop. I have no financial interest, but just it is easier and they can be sterilized. This is a surgical gonio lens. I am targeting the trabecular meshwork, this air, as I said, due to not enough pressure. Here is the trabecular meshwork targeted by the hook. You can do it by the traditional sensitive hook after incision, and I get it back. Here's a cleft starting to appear. I have taken about 90 degrees, 4 clock hours only from the angle as recommended in the literature, and will be enough. The second case is a case of steroid-induced glaucoma, 7-year-old boy. The first eye, I have done rigid probe external trabeculotomy, and I got good results because in a lot of Japanese papers, they are routinely using the rigid probe external trabeculotomy for the steroid-induced glaucoma as the pathology in the trabecular meshwork. So I have decided to do ab internal trabeculotomy using the Tanito microhook for the second eye. And the preoperative IOP was 23 millimeter mercury with 2 glaucoma medications, and the postoperative was 12 with 1 glaucoma medication. Over 2 weeks, follow-up, and I am still waiting whether I will withdraw the treatment completely or not. This is phakic patient, and also I am excising the trabecular meshwork under the surgical gonio lens, and I reverse my hand and go in the opposite direction for 4 clock hours to complete the excision of the trabecular meshwork, and the cleft is starting to appear here. So what are the pros for the MIGs? Fast recovery, less impact on daily activities, fewer post-operative visits makes these procedures excellent, especially for elderly patients, reduce the risk of damaging other structures in the eye that may necessitate additional ocular surgery. What are the cons? Long-term outcomes for many MIGs procedures are still not yet known, and there may be unanticipated risks associated with these devices and surgery. Careful post-operative care is still required to achieve good outcome because patients undergoing MIGs are still prone to post-operative complications such as IOP spikes, device movement or erosion, hyphema, and steroid-induced elevation of IOP. And in conclusion, the field of MIGs has expanded rapidly in the last decade, adding to the glaucoma surgeons' armamentarium and their ability to tailor their surgical approach according to each specific patient. The advent of MIGs surgery has allowed for improved management for cases with mild to moderate glaucoma. And in Schlemm canal and angle-based MIGs, better outcome can be achieved in patients in whom the pathology is in the trabecular meshwork, like pseudoexfoliation, pigmentary glaucoma, juvenile open angle, and steroid-induced glaucoma. MIGs can be easily incorporated into routine phacoemulsification and can be used in patients who are well controlled and need to decrease or get rid out of their drops, although they are well controlled. But MIGs are not in competition with trabeculectomy when you need low IOP pressure and the patients with advanced disease. And finally, future devices and the surgical approaches will continue to develop in the coming years. And thank you very much for your attention. Thank you.
Thank you very much, Professor Tarek, for this excellent presentation. I would like to ask just one very short question. From your point of view, sir, if I have no previous experience with MIGs and I want to start this very interesting new world, what would you recommend me to start? Which procedure would you recommend me to start with as a total novice, a total beginner? I know nothing about MIGs. Which procedure would you recommend for me to start with, please?
I think the first thing to do is to master using a surgical gonio lens, and the available procedure here in Egypt, I know a lot. They are very good colleagues doing MIGs, GAT, and getting good results. But whatever, you should first start to master using the surgical gonio lens under the surgical microscope and to be familiar with the trabecular meshwork. In the last few months, after every case of phacoemulsification, I was putting the surgical gonio lens and just touching the trabecular meshwork and getting out. And this has taken some time from me to be familiar. And up till now, I'm still in the learning curve. And after that, the best for us here, I think, is the incisional types of MIGs, whether GAT or excisional ab interno trabeculotomy. Because in Egypt, actually, we don't have devices, and we are lucky because in the updated literature, there is no significant difference in the Schlemm canal surgery between the devices and the excision. But as regard the suprachoroidal, there is still some work for improvement because some authors are saying that it can be used in moderate to severe and also in the Zen and the InFocus, but I think this needs return back to the literature, and these devices are still not available. I know we don't have a long-term clinical background to judge these devices.
Do you think, sir, we can use a regular insulin needle for such a procedure, an angle procedure, or do we need? Yes.
Yes, you can. If you have Kahoot, that's okay, but it is expensive. It is a single use. If you have something like Tanito is actually since Kahoot, but it has sharp edge. And in his first publication, 2017, he said that I was doing the first incision by the MVR and then completing the incision with conventional Sinski hook. Sinski hook were all. Yes, and also some MIGs surgeons are now doing the 25 gauge insulin syringe 90 degrees tint, and get the puncture to the trabecular meshwork and get the excision by the sharp edge, and they are typically doing like the Cahook dual bleed.
Sure, sir. Thank you very much, sir.
Thank you, Dr. Tarek Bey. And actually, when somebody with the caliber of a high glaucoma specialist, like Dr. Tarek Ragaiey, mentions that he is still in the learning curve just to touch the trabecular meshwork ab interno while he is practicing this even on his cataract patient, this tells us that the theory is excellent, but in practice, it is not that straightforward and just easy to run after. So we have to be wise in our picking up. And actually,
it takes time. Yes.
It takes time with this high caliber glaucoma specialist. And actually, these are, with the Tanito needle or with the Cahook, we are just trying to perfect the goniotomy, actually. So the original idea of goniotomy, when it was first devised, just to cut the trabecular meshwork.
Yes.
But then he couldn't do that in the adult eyes. And just for you to know, the first publication for goniotomy was not for infantile glaucoma or congenital glaucoma. It came in 1936, and it called also by the way, gonio trabeculotomy. So the name trabeculotomy is mentioned even in the 1930s. But afterwards, he was very smart, Otto Barkan. Otto Barkan was very smart, and he realized that he is not doing real trabecular surgery. He is a very smart, he is a very humble surgeon and genius. So he converted the name from trabeculotomy to goniotomy until we were able in the 1960s actually to perform the trabeculotomy ab externo we developed along the past few decades. So Dr. Tarek Elbromboly, once and again, thank you for this.
Yes. One more minute. Sorry, Dr. Ahmad. One of the sentences I have read in a recent review for the MIGs that goniotomy is the mother of MIGs. Yes, this is true. Goniotomy is the mother of MIGs. And in Japan, and you have very good experience, they are doing a rigid probe, external probe trabeculotomy, and comparing it with something like Tanito. They use Tanito micro over there in Japan, comparing it with the ab externo, the ab interno in cases of primary open angle glaucoma or in glaucoma where the pathology is in the trabecular meshwork.
That's very true. That's very true. So I think, yes, trabecular surgery and this angle surgery in various forms will come to the forefront in coming years. Not the exact MIGs of today, but probably in the future we will know more and we will develop more techniques into this trabecular surgery.
Sure.
Thank you, Dr. Tarek Ragaiey, very much. And now we move to Professor Dr. Nader Bayoumi. We would like to hear from him and his updated knowledge on the new molecules now used in glaucoma treatment. We stayed 100 years or more on the pilocarpine. In the early 1970s, the beta blockers were introduced after maybe more than 8 years of nothing but the pilocarpine and its similar drugs. And then we stayed with the timolol or the beta blockers for another 30 years. And then by the year 2000, there came the plethora of the drugs we have today, the prostaglandins, the alpha agonists, the topical carbonic anhydrase inhibitors. And from 4 years back, totally new molecules are being introduced. So we would like to hear about them from Professor Dr. Nader. Dr. Nader, please.
Thank you very much, Professor Ahmad Khalil. Thank you very much. In the coming few minutes, I will just give a very brief, let's say, a brief update on the present future, actually, as Professor Khalil noted in the very beginning, many of these drugs are already in use somewhere else in the world. So, if we follow the flowchart of glaucoma medical therapy updates, there are updates regarding the active ingredient, and there are updates regarding the method of delivery to the eye, and there are other additional unconventional IOP lowering therapies, which are a matter actually of considerable debate. So we're just going to mention them just as an enumeration. About the active ingredient, there are still the classical classification into an IOP lowering therapy and non-IOP lowering therapy. For the method of drug delivery, there is now an extraocular or an intraocular method of drug delivery, and these unconventional IOP lowering therapies include things like yoga, meditation, and gene therapy. Now, about the IOP lowering therapy, the new active ingredients, there are new classes of drugs. For the non-IOP lowering therapy, there are other strategies or approaches like inhibition of activation of astrocytes, inhibition. These are mechanisms involved in the damage of the neurons, whether at the level of the optic nerve head or within the retina, such as the activation of astrocytes, nitric oxide synthase inhibitors, systemic blood pressure manipulation, vascular autoregulation, oxidative stress, metalloproteinases, heat shock proteins, neuroprotection. All these are non-IOP lowering therapies for glaucoma that are being devised in the present and in the near future. They would be available. For the method of delivery, the extraocular delivery, there are either retained devices or there are direct application of certain molecules that we're going to show shortly. For the intraocular delivery, the delivery may be intracameral or subconjunctival, that is, the implant is placed either into the anterior chamber or in the subconjunctival space, I was going to demonstrate shortly. The new classes of drugs, they still follow the same plan of either decreasing aqueous inflow or increasing the aqueous outflow. And for the extraocular delivery systems, the direct application, there are either micronized preparations or nanoparticles, as we're going to demonstrate right now. And for the aqueous outflow, we still follow again the same classic flow chart of conventional pathways, that is the trabecular meshwork pathway or the uveoscleral pathway, or both together, but there are new molecules achieving this target. So now let's have a quick screening of what new active ingredients are available. There are classes called Rho kinase inhibitors, nitric oxide donors, adenosine agonists, and there are newer prostaglandin analogs, and the new modalities, as we've mentioned, the gene therapy, RNA modifications, and antibody therapy. So what's this about the new first class of active ingredients, the Rho kinase inhibitors? What do? They regulate the contraction of the smooth muscles, vascular endothelial, and other cell types. So their mechanism of action, they would enhance the outflow through the trabecular meshwork. They would decrease aqueous humor production. So they would act thus by the dual mechanism. And there are still studies about whether they decrease the episcleral venous pressure and whether they have an antifibrotic effect on the trabecular meshwork. What are the molecules currently available? There is the molecule called ripasodial hydrochloride hydrate, known commercially as Glanatec, netarsodil, known commercially as Ropressa, and the combination known as Roclatan, which is a combination of netarsodil and latanoprost, the conventional F2 agonist latanoprost that we know. So the ripasodil is a specific ROCK inhibitor used primarily as an adjunctive agent. Netarsodil, known as Ropressa, the trade name is Ropressa, results in a few cases of corneal verticillata, and the combination combines the dual pharmacological mechanism of action and hence may both decrease the inflow and increase the outflow. So we have three preparations so far available for the Rho kinase inhibitors: ripasodil, netarsodil, and the combination known commercially as Roclatan. Second class of active ingredients are nitric oxide donors, for which we have two examples. A drug called Vyzulta, the trade name, the active ingredient would be latanoprostene monod, and the other is NCX667, Nicox, which is still experimental. Latanoprostene monod has a dual mechanism of action in that it produces overall relaxation of the trabecular meshwork and inner wall of Schlemm's canal and the ciliary muscle, and it reduces the aqueous humor formation. That is, in other words, it decreases the inflow of aqueous humor and increases the outflow through the trabecular meshwork and the uveoscleral pathway. The other NCX is still an experimental drug, so we're not going to discuss a lot about it. What about the third class or the next class of new active ingredients? These are adenosine agonists, for which we have only one example or one molecule, which is by the trade name of Inotec, and the active ingredient is trabodenosone, and it's a highly selective adenosine A1 receptor. What do adenosine agonists do? They perform upregulation of certain molecules in the eye called the protease A and matrix metalloproteinases, and these play a major role in increased resistance to aqueous humor outflow through the trabecular meshwork. So they target the aqueous outflow through the trabecular meshwork. And treatment with trabodenosone does not affect the rate of the aqueous humor production, it affects only the aqueous outflow. The next class would be prostaglandin analogs. We already know prostaglandin F2 analogs, for which we know the famous molecules like latanoprost, travoprost, tafloprost, and bimatoprost. These are a new class, or they target a different class of prostaglandin receptors, which is the EP2 and the EP4 receptors. The molecules we have are by the names of 3,7-diethylPGA1, omidinipag isopropyl, which is produced by Santen Pharmaceuticals, and Santen at no commercial interest, of course, as another product which is called savitaprost. So what about these? The prostaglandin EP2 and EP4 receptors have different effects on the trabecular meshwork cell than the Schlemm's canal cells. Some of these receptors, when activated, they increase cell stiffness, and others they decrease cell stiffness. So by manipulating this cell stiffness, these drugs can enhance the outflow through the conventional drainage pathway. Remember that the older prostaglandin analogs enhance the outflow through the uveoscleral outflow. So we have new prostaglandin analogs that would enhance the outflow through the conventional drainage pathway. The molecules are a selective EP4 antagonist. The other one produces a little bit of conjunctival hyperemia, and the third one facilitates both outflows through the trabecular meshwork and the uveoscleral outflow. What about the new modalities? Gene therapy, RNA modification, antibodies. Just a quick note, gene therapy, we all know, of course, of the CRISPR technology being used right now. The RNA operates by the trade name of palmosiran, and antisense oligonucleotides is the third class. The non-IOP lowering therapy, the current trend is about neuroprotection, and this is a whole big issue that is still so far experimental, so we're not going to discuss in this presentation. And we move to the next innovation in glaucoma medical therapies, which is the method of delivery. That is, how do we deliver the active ingredient to the eye? There are some innovations about that. The drug may be delivered extraocular by two methods, either retained devices or by direct application, for which we can use either micronized preparations or nanoparticles, or intraocular, for which we can insert the implant either intracameral or subconjunctival. Let's have a closer look. What are the indications for these new modalities of administration of the drugs? These are for patients mainly with poor adherence to topical drop management, or those with limited access to an ophthalmologist, those who cannot visit an ophthalmologist frequently. So these devices can be extraocular. These are in the form of sustained release formulations and devices. The ideal one, of course, would have or should have a long duration of efficacy, a good ocular adverse events profile that is minimal or no side effects, a bioerodible system to minimize the need for invasive removal, that is a device that would degrade in itself with no need to remove that device, an office installation rather than an OR installation, and rather than going into the operating room to instill it, and the active ingredient should provide sustained IOP lowering effect independent of factors like circadian rhythm and aqueous humor formation. Of course, when we enumerate lots of ideal characteristics, this of course is an indication that it still doesn't exist. So what are the examples that are available now in the market? There is the bimatoprost ring produced by Allergan. Is a device that is inserted is a device that rests on the surface of the eye under the eyelids and releases bimatoprost. The topical ophthalmic drug delivery system by Amorphex Therapeutics is a soft, flexible device that floats on the tear film and is concealed under the eyelid and can be removed by the patients themselves. So what about direct application? Direct application of the active ingredient to the eye rather than by devices. There are two methods. These are the nanoparticles and microdoses. So what about these? As you can see, this is like a sprayer, a sprinkler. that delivers latanoprost with high precision, a piece of print microdose delivery. It delivers doses of 8 microliters of latanoprost to the eye. Now, if we remember classical teaching, we know that the commercial eye drop, the least, is about 50 microliters, and we know the conjunctival cul-de-sac holds only around 17 or to 20, something like that. So we all know that the conventional eye drop is 3 times, actually threefold what the conjunctiva could hold, with all the disadvantages that we know for this. This new system delivers just 8 microliter micropulses to the ocular surface, definitely reducing the side effects associated with excessive drug product and preservatives. What about the intraocular route? There are the intracameral, like the bimatoprost sustained release biodegradable implant produced by Allergan, which has so far proved a favorable safety profile. And there's the Invisia, which is an implantable travoprost introduced into the anterior chamber, the intracameral, which is also well tolerated. Other implants include the Polyactiva implant. This is again a slow release of travoprost into the eye, and the iDose of Glaucos, which is another travoprost, another sustained release travoprost intraocular implant, and it's comparable to a usual microinvasive glaucoma surgery. We've just been speaking about MIGs. It's comparable to the MIGs surgery. What about the other route, which is subconjunctival? Rather than penetrating the globe, you insert the implant in the subconjunctival space. These subconjunctival implants or depots obviously have the advantage of reducing the potential for corneal endothelium adverse events, and it is less invasive. Of course, you're not entering the eye, it's just underneath the conjunctiva. Yet, the drug administration is farther from the putative site of action, that is where it should act, and the ocular safety profile in terms of its hyperemic effect on the conjunctiva is still an issue with these medications. What preparations are already available? There is the liposomal depot form of latanoprost called Peregrine, produced by Peregrine Company, and the advantages of the nanoliposomes is that they are relatively stable. They can be introduced with a small gauge needle, and the suspension formulation maximizes the amount of drug that can be loaded into the subconjunctival space. There are other drugs, which is the latanoprost loaded bioerodible version of Duracert, another company, and there is the VS101 latanoprost insert. So these are different devices that insert the active ingredient of latanoprost in the subconjunctival space. So far we have bimatoprost intracameral, travoprost subconjunctival, and latanoprost subconjunctival as well. These are methods of drug delivery system that are new. Now I conclude my talk by just a reminder about this unconventional therapy, which is still a matter of considerable research and debate, which include gene therapy, stem cell therapy, yoga, and meditation, not to mention, of course. Thank you very, very much for your attention. Thank you. Dr. Ahmad Bey, you're muted, sir. Dr. Ahmad Bey, unmute, please, sir.
Thank you very much, dear Nader. Sorry for that. For this very easy to understand update on the new drugs, which I actually we all need to know about and follow, because they are going to be in the Egyptian and the Middle Eastern market in short years to come, actually. And I was contacted by some company a couple of years back telling that they're going to bring it to the Cairo, actually. So we are expecting these drugs, as they are already a mainstay of treatment in other countries, as I mentioned, in Japan and in the US. So thank you very much for this nice update.
Yes,
and for time constraints, we finish this session. And I just make a small announcement for the upcoming 12th and last session, which probably and hopefully will be a very interesting one, because it would contain best of the best what has been presented in the Glaucomatology 2020. So it is top of the highlights of the past 11 episodes. Please be with us next Friday at 8 p.m. God willing, see you all well then. This will be followed by the CME tests for the last 6 episodes, and also for people who didn't pass the first 6 episodes or the first part, the same examination will be repeated for them if they would like to try again. So thank you very much, and see you well next week.
Thank you.
Thank you very much, sir.
Thank you.